Today we are going to learn the differential diagnosis for global paralysis of gaze, or it is called as total ophthalmoplegia. What is global paralysis of gaze? The characteristic feature of it is that patient is unable to look voluntarily in any direction. He will not be able to look in any direction. And we know that the location of the lesion can be in the frontopontine tract for saccades, and parieto-occipitopontine for pursuits. Now coming to the differential diagnosis, we have divided into two, whether it is an acute total ophthalmoplegia or a chronic progressive total ophthalmoplegia. If it is an acute total ophthalmoplegia, the most common causes are not the stroke but Miller-Fisher syndrome, Guillain-Barré. Then third number we have the bilateral pontine or midbrain thalamic stroke. Myasthenia gravis should be ruled out in every patient who is presenting to you with total ophthalmoplegia. Other causes are pituitary apoplexy, botulism, anticonvulsant intoxication, so the drug history is very important, and multiple cranial neuropathies from infection or neoplasms or Wernicke's encephalopathy. So if a patient is coming to you with acute total ophthalmoplegia, what are the various investigations? We need MRI to rule out the structural lesions. Secondly, we should rule out GBS and MFS by doing nerve conduction study and by CSF. Thirdly, CSF is also important to rule out underlying any meningitis or encephalitis. And for botulism, we need the EMG or RNS or the stool for the botulinum toxin. Every patient with total ophthalmoplegia, neostigmatitis should be done. Now, what are the other causes for the chronic progressive total ophthalmoplegia? We have chronic progressive external ophthalmoplegia syndromes, oculopharyngeal muscular dystrophy. This is very important because this entity present at the age of 50 to 60 and patient will present with the ptosis and generalized weakness. Then another entity is myotonic dystrophy, congenital cranial dyssynervation syndromes, various neurodegenerative disorders, which we always keep first possible when we have a patient with a total ophthalmoplegia. Which first possibility comes in our mind? It is PSP, but it is less common. Then myasthenia gravis and thyroid eye disease.